turn it over to Amanda Hudson-Frigault. And Amanda is going to build on some of what Martine has said and what that means in her practice. So she holds a Master's of Counseling Psychology. She's currently the Provincial Take-Home Naloxone Program Coordinator with Health Promotion and Addictions and Mental Health at the Nova Scotia Health Authority. And Amanda has worked as a health promoter for the past 12 years. And some of that, when we talked earlier, some of that was in really close intersection with public health specific programs and professionals. She has a real passion for supporting communities so that people can thrive right where they live. She has worked to support healthy public policy development, grassroots capacity building, and a community sense. And in her work, it's really important to apply that culturally competent and gendered lens, and that's been really central to supporting change in culture and stigma around substance use. And we had a good chat around opioids, and we had a good chat around cannabis and marijuana, which are all huge hot topics. So with that, Amanda, I'm going to turn it to you. Amanda, are you there?
I am. Good afternoon,
great.
Everyone.
Go ahead.
So, good afternoon, everyone. Thanks so much for the invitation to join you today. Hopefully what I'm able to share does sort of segue nicely with what we've been chatting about with Martine. And this really is my own thoughts and perspectives when it comes to the experience I have had as a health promoter. So, as was mentioned, currently I am the Take-Home Naloxone Program Coordinator. And just in case anyone was curious as to what that is, it is sort of positioned within the opiate treatment program. So I have worked for a number of years in the addiction side of the mental health and addiction program. And so naloxone is also known as Narcan, which is a harm reduction tool that is certainly used currently with some of the opioid concerns and use that we are having across the country. But that's certainly not what we're here to talk about today. But it certainly does relate to my current role as well. But previous to that, I had a significant opportunity to spend time working in health promotion, and my thoughts on that are how relationships have greatly benefited in moving my work in health promotion forward. So this is really just meant to be a reflective example of my own work. And even though my current role maybe has a slightly different take to it, I found that still relationship building that I'm going to talk about today has been very critical to that. And it was sort of briefly mentioned a moment ago, but often us in health promotion work, we're often outward looking. We spend often time sort of working on how to precipitate like environmental changes, community, population, individual interventions. But what I'm really sort of proposing today is sharing my thoughts and experience on how I have found being introspective sometimes on how we as individual health promoters can sort of contribute to that dynamic of health promotion work. You know, sort of looking at our own approach, our own style of how we leverage some of these intervention points or access points can really change a lot of the outcomes or really influence the approaches that we actually take. But before I go any further than that, I'd be remiss if I didn't take a moment to mention Health Promotion Atlantic as well. I've really been privileged to have the opportunity to volunteer and be part of Health Promotion Atlantic. So if you have the opportunity, any of my colleagues out there that are joining us today that are on the East Coast, New Brunswick, Newfoundland, Labrador, PEI, and the rest of Nova Scotia, please have the opportunity, if you haven't already, to join. When you join, you certainly also get access to Health Promotion Atlantic, and we're always looking for new people who will support that as well and be part of our group because there is exciting work happening. So how have relationships been a key point? How has this actually advanced the concept of collective lifestyles approach. So first of all, when I mention relationships, what I'm actually referring to in this context, I am somewhat referring to the broad or systemic, even organizational concept of, relationships. That could be employment roles, organizational membership. Those are all pieces that do somewhat dictate who you're going to have the opportunity to connect with, what your actual role or specific mandates may be within, for example, your employment role. But I'm also referring to the more interpersonal relationships, and that's probably the bulk of what I will speak about today, because I have found that it's really those interpersonal relationships that have been proven to be very powerful. It's often those that you have the chance to have the informal conversations with, the opportunity to have those brief interactions with, to be able to build that interpersonal connection. Those tend to bear the most fruit. So while we've already talked about that the collective lifestyle approach is similar to the settings or social context approach, it takes into account, the social, cultural, economic environments, essentially the social determinants of health. However, when we use the settings approach, certainly it is a very popular approach. I know that, again, has been mentioned because there is sort of the concept of the captive audience. Usually the settings approach, you have an individual group that may experience common risk factors, and that could be your entry point in the aspect of it being topical or somewhat, but that is not always necessarily bears the most success. It doesn't always necessarily follow best practice as well. So there is potentially inadvertent harm or re-traumatizing that could happen that I would like to sort of give an example of when we perhaps do take that approach where we sort of try to get the biggest bang for our buck by using sort of that captive audience concept. And I use the analogy of perhaps a school-based intervention presentation that hasn't necessarily been perhaps framed up the most appropriate way. So pretty much all of us have probably had the experience where you have attended a school-wide assembly or perhaps have participated in those yourself. So while we may be reaching a large number of individuals when we participate in, say, an intervention in a school context, and it certainly may be easier to contact people, but we're making a really big assumption that they have, significantly or relevantly common shared experiences simply because they attend the same school. And when things have not necessarily been framed up appropriately, there could be some of those inadvertent effects that I mentioned. Say, for example, maybe there is a topic that could be very triggering for certain individuals, and if proper supports are not put in place based upon that topic, we know that those can actually have some inadvertent harms that we didn't necessarily intend to begin with. So when we have that conversation, usually that takes us down the road of, well, perhaps we should be tailoring the presentations a little bit more, or we should be offering them to targeted populations within that school setting if we're using that example. But when we do that, we're, again, back to the limitations of either an issues or risk-based factors approach. And again, there's inadvertent harms that potentially could arise from that, such as anonymity being lost, individuals perhaps feeling identified, and that in itself can cause further stigmatization. So another example of how relationships have really benefited some of my roles, and especially in building trust in the community. So relationships have been so important because certainly they've increased my own knowledge base, but it has borne out to increase different opportunities for collaboration that I've been able to take advantage of. It's allowed me to increase trust with different groups that I've been able to work with. Certainly, as I mentioned before, it can decrease that individual focus, Many times, perhaps individuals have had the experience of stakeholder fatigue. Perhaps there's been a particular population, community group that you wish to engage with, and the response perhaps has been that they have experienced these asks or has had the opportunity to share multiple times, and that can actually cause fatigue. Perhaps individuals have gotten the response of over and over again, that maybe hasn't been taken into account, and that can, in effect, actually damage a lot of trust if that population or group does not feel that what they have voiced before has actually been listened to or taken into account. And certainly we mentioned before, a really great point was brought up in the comments in the chat here around certain labeling could perhaps increase blaming or victimization. So by building some of these relationships, it could potentially bear out that some of those situations where labeling or stigmatization or even aggravating some of those health inequities can be addressed. One example that I'd like to share is my experience that I had working within public health. Approximately 3 years ago, I had the opportunity to be invited to participate in a structural move within the Nova Scotia Health Authority in building a collaborative relationship between physicians within public health. And this was very important, much needed, and definitely was a great opportunity that I wanted to take advantage of. Having said that, oftentimes health promotion doesn't necessarily have that sort of systemic direction, and that was certainly the case that we experienced here. So while there was certain commitments and certain buy-in engagement to move these relationships forward, we found that building those individual relationships ended up being where the advantages came from. It's very difficult to sort of mandate relationships or to mandate connections. Again, perhaps people joining have had the experience where it's really difficult to sort of say, go out and collaborate with, this particular group. That necessarily isn't functional and doesn't always actually succeed. Very rarely does it, I would say. So by developing those types of interpersonal relationships with public health colleagues, we were able to move a lot of work forward. And I'll give a specific example around cannabis. So within the Nova Scotia Health Authority, we have several health boards, community health boards, which are volunteer-based community members who are able to give feedback to the health authority in different approaches. And several health boards had approached us in concerns around cannabis legalization at the federal level and what that would look like at the provincial and community level. So certainly both public health and mental health and addictions programming were approached. This gave a very unique perspective, and I think it sort of highlights some of those systemic issues that perhaps we experience in our day-to-day work, whether that be more of a grassroots, health promotion versus sort of a clinical approach, that sort of healthcare approach. And we were able to really leverage different relationships and build a level of trust, because certainly past experience can sort of change the lens that different community groups are approaching with. While that entry point was certainly topical in that they were specifically looking to have conversations around cannabis, we were able to sort of leverage that into larger health promotion, what are healthy public policy, and how can the community directly influence healthy public policy. And so that ended up being a very successful relationship that we're able to continue to draw upon and continue to build upon. So I did want to share one poll. Now that I've shared a little bit of my perspective on how relationships have benefited my health promotion work, I'd like to hear your perspective on how you feel health promotion, building relationships in health promotion has advanced your work.
it's interesting, right? Because I think, you know, a lot of us would say that it's important, and maybe we can get to this a bit in the question and answer, is how do we do it?
Absolutely.
Yeah. So very important, somewhat important.
Yeah, so rightly so. It is a bit of a loaded question because I think in practicality and sort of philosophically, we all would definitely say that relationships are important, but in practicality, how those actually bear out and how we're able to actually implement them in our day-to-day work, that is where the waters perhaps get a little bit more muddy because there could be constraints that are placed upon us and how we are able to make those different approaches, right? Our roles, systemic, funding, what our mandates are, what level of autonomy we have in our work, all influence in how we potentially approach some of those relationships, right?
Mm-hmm.
So what I like to say is in these situations, the total is greater than the sum of its parts. So we already sort of have a concept of what that collective lifestyle approach is from what we discussed previously. So we understand that individuals and structures are constantly interacting with each other, which creates sort of an outcome that is greater than the sum of any of those parts. So when we're building relationships, especially with some particular populations, communities, I'll use First Nations communities as an example, we really do have to recognize and honor some of the lived experiences in those communities. That's very critical. We also need to take it a bit further. Not only, sometimes we tend to be a little bit more focused on whether an intervention is effective or not. But in order to understand if an intervention is going to be effective or not, it's not purely outcomes driven. Sometimes we do have to uncover how the intervention in and of itself works. What's the mechanism behind it that is so critical? So relationships, again, they're so important because we're often not going to be invited to the table if we haven't begun the conversations or developed a basic relationship with a community or population that we're trying to engage. They're not a means to an end with the end goal of behavior change. Well, I know that may be sort of what us as health promoters are sort of used to trying to address, but really it's rather a way to better understand someone's life chances. So when I say life chances, what we mean is what opportunities or lack thereof opportunities does a person encounter due to their social circumstances. Life chances are going to constrain or enable those life choices. So they're very much interrelated. Life chances, if we want to sort of use that term, are really closely related to the social determinants of health, in my opinion. We know that there's often situations, circumstances, such as whether it's your socioeconomic standing, environment, that directly influence us. And they're not necessarily something that we always have great control over either. So previously, there was sort of the term of vulnerability that had been mentioned, and that still potentially could have some labeling or stigmatization impacts. So that's sort of what I'm proposing is perhaps a concept of life chance is one to consider in addressing some of this stigmatization. So how can we as health promoters enhance this concept of life chances? So again, how can we truly understand the nature of a population, group, or setting or individual's life chances without having previously established a functional relationship? So within the chapter, if and when the rest of you have an opportunity to have read it, one of the quotes in there is that both chances and choices are socially determined, and thus choice cannot simply be individually controlled. And again, I think this leads back to that concept of stigmatization, especially within my work within the addictions field. Constantly, that is a barrier that we have to address, is sort of the assumption that people do have choice or free will about their personal circumstances when it comes to their substance use, but we know that that is a greatly oversimplification of the situation, that there is such a broad and such a complex dynamic that's happening in addressing someone's substance use. There's also the concept that nowadays we are more socially influenced than I would pose than perhaps ever before. The current social media environment, relationships today are often very tangential, while having human contact, having those core interpersonal relationships we know are so key and core to mental health as well and our lifestyles overall. So even though we are more socially influenced than ever before, some of the social settings are very remote, online, with a lack of direct human contact, but they're so prevalent, and I would say that they're a driving social construct right now. And social media is influencing as what we see as routine, normalized, habituated to. And so when we put all of those things that we've been exposed to and habituated to, we know that that really informs our lifestyle, or the concept of what we have as a lifestyle as well. Think of the concept, say, for example, of the Kardashians and the invention of, or the proliferation of the selfie, status, how we conceive of that. To me, it's more than just the concept of, what we used to use as a cliche of keeping up with the Joneses. It's much more than materialistic in the sense nowadays, but it still does influence the overall concept of behavior. So based on that, is choice really an illusion we have just created for ourselves so that we feel we have autonomy and some agency? Not necessarily is my response to that. Of course, it is a two-way street. I'm sure everyone has seen the Margaret Mead, quote before. We certainly have common socially acceptable behaviors in Western culture and practices in different communities that are going to influence us at the individual level or at a larger group social level. But at the individual level, we can, in fact, transform social practices. So small groups or individuals can actually influence that. Going back to my previous comment, there has certainly been many, many examples where that has been the case. A single individual has had great influence. So previously, Martine mentioned a study of smoking that people who smoke early attributed to the changes that they made in their smoking behavior to legislation changes or those broader healthy public policy changes. They really felt that their own capacity as change agents or the effects of structure versus agency together was the driving force, but we know how much influence the actual policy changes do contribute to that. They can't really be teased apart. So one question that sort of leads me to pose is, today's social media culture, an opportunity for health, is it an opportunity for health promotion to begin to influence social practices, continue the movement away from an individual approach as an entry point? And how do we take it further than simply having, health promotion as a social media presence, which I'm sure many have had experience with or have tried. It has been attempted, and sometimes with limited success, but rather is it an entry point to leveraging those relationships that we can establish.
So Amanda, we're very short on time now.
Sure.
And so what I'm wondering is if we could actually, we've got a few questions coming through.
Yes.
I'm wondering if we could actually pick up that conversation around agency and environment, that whole intersection, and maybe open it for some questions. We've had a few come through. So is that okay?
That sounds great.
Okay, great. Thank you very much for that. Your experience is obviously really rich and really long, and I know that there's some really practical things in there. So we had one question a little earlier